Greetings, doctor. You want to try out your slides? Doctor, you're not audible.
No, I do not have any slides. I'm the chair. I'm chairing the session.
Okay, doctor.
Hello.
Hi, sir. Can you hear me?
Yep.
Okay. Are we both the only people who have joined?
Yeah, let the others join. So we'll start at 7. So
Okay.
just want to make sure it's working. That's the reason I joined early.
Yeah.
Hello, hi sir.
Hi, Dr. Vikrant. How are
Hi.
you?
Good sir. How are you?
Good,
Long
good.
time. Seen you after a long time.
I know. Since COVID, I think.
Yeah. Maybe last time I met you was in 2019, maybe during the CSPLD or something.
Yeah,
When
and
you and
that's
Dr.
right.
Prashant had come together.
After that, we met at the this thing, literature search in in Raipur.
Yeah.
I think that was the last time.
Yeah, I think so.
Good evening. Hi.
Hi, ma'am. Hello.
Hi, I'm Dr. Ramya.
Yeah, hi.
How is Dr. Seema doing well?
Yeah, she's fine. I'm just trying to join from my laptop. I've joined from my mobile, so I'm just trying to
Okay.
join from the laptop if possible. दूसरे लैपटॉप देना
Dr. Webel, you are muted. You are muted. Audio is muted.
Am I audible, sir? Hello, sir. Good evening.
How are you?
I'm good, sir. How are you doing?
I'm good. Thank you.
Great, sir. Hello, ma'am.
Hi, good evening. How are you?
Good evening, ma'am. I'm doing good. Thank you.
Yeah.
Vikrant sir is also here now.
Yes.
Yeah,
He's
he has
checking
joined.
the slides.
Yes.
I think
Okay.
I joined
Yeah.
some time back, but I was trying to join from laptop. It doesn't seem to be working, so I may have to do it from the phone itself.
Good evening,
think
sir.
so. So can we try sharing the screen and can we check whether it's working?
Yeah, I think we should.
Because
Yeah.
I'll be doing from my phone, so I may have to actually see how it works.
Yeah.
Please check it out. Hello.
Good evening, everyone.
Good
Good
evening.
evening.
Sorry, I was stuck up in the traffic, just reached my home.
You are able to see.
So
It's in PDF format.
no, is the screen visible now?
Yeah,
Yes.
working.
And are the slides going forward?
Correct.
Yeah.
Yeah, so I think I should be able to do it from the phone itself.
Yeah.
Although
You
your
have it
sound is not very clear, but I think it would work.
Okay, let me just try. I'm trying to connect through the laptop also.
No, this is working fine. I
Yeah.
think probably speaking close to the microphone would rather help.
Okay, sure.
And now the voice is clear. Yep,
Yeah, so I think I have to hold the phone slightly closer to myself.
true.
Yeah. So I will stop sharing screen now.
I think Dr. Webel also checked.
Yes, sir. Yes, sir. I'm sorry. Is it visible, sir?
Yes.
Yeah.
Okay. Just a minute. Is it working?
Yeah.
It's moving. Yes.
Yeah. It's
Okay.
going well.
My voice is clear, sir?
Yeah.
Okay. Thank you.
Great. So all the best. Another 3 minutes to go. We'll start at 7 sharp.
Is anybody else supposed to join with us?
No, so the participants have a different link. They'll be joining through the IAP website. They won't be visible here. This is a link exclusively for the speakers, moderator, and chairperson. And I have joined as a part of Gapio. So otherwise, I think this IAP, there's someone from IAP who's coordinating.
Okay.
Yeah. Over to you. All yours. Thank you.
Dr. Ashay,
Sir, good evening.
how are you?
Hello, sir. Good evening. Vipul, sir. Good evening. Vikrant, sir. Sushil, sir.
Hi.
Dr. Ramya,
Hello.
hi.
Hey, hi.
Doctors, you can start the session.
Yeah, okay. So a very good evening, good morning, and good afternoon to all the friends as per their respective time. I am Dr. Ashay Shah, pediatric gastroenterologist from Ahmedabad, Gujarat, India. Welcome to this digital platform of Gapio and Indian Academy of Pediatrics. And I would like to express my gratitude to all the esteemed speakers, chairperson, and moderator, and also viewers for joining this webinar well on time. As you all know, that today's session is on pediatric hepatology. And to conclude further, I would like to invite a young dynamic lady, a pediatric gastroenterologist from Cochin, Dr. Ramya Pai. Welcome, doctor.
Good evening and good morning, everybody. Hi, and welcome to the IAP Gapio International Lecture Series. As Dr. Ashish said, I'm Dr. Ramya, and I'm a pediatric gastroenterologist from Lisi Institute of Medical Sciences from Cochin. Today we'll be having a session on pediatric hepatology. We have two lectures ready for you today. One is on atypical presentations on viral hepatitis, and the other one is on autoimmune hepatitis. These two topics are very important to us for our day-to-day clinical practice. To chair the session today, we have with us Dr. Bhanu Vikraman Pillai, sir. He's a consultant and head of the Department of Pediatric Gastroenterology at Amrita Medical Sciences, Kochi in Kerala. Dr. Bhanu served the Department of Pediatric Gastroenterology in various universities in the United States for about 17 years. Let me invite Dr. Bhanu to introduce our elite speakers to our audiences. Over to you, sir.
Thank you, Ramya. Thank you very much. And good evening, friends, and good morning or good afternoon, depending on where you are. And it's my privilege to introduce two of my friends, Dr. Vikrant Bihari Lal and Dr. Vipul Gautam, to deliver the talks today. Dr. Vikrant is an associate professor of pediatric hepatology at Institute of Biliary Sciences, Liver and Biliary Sciences in New Delhi. And he is an extremely academic person with more than 65 publications to his credit. And thank you, Dr. Vikrant. And all of you know the acute hepatitis A and the typical presentation everybody knows with coming the fever, abdominal pain, jaundice, tiredness, things like that. But he is going to focus more on the atypical presentations of acute hepatitis A. Dr. Vikrant, please proceed. Meanwhile, may I invite all the listeners to post your questions in the chat box, and definitely we will try to answer almost all of them if time permits. Please, Dr. Vikrant, please proceed.
Thank you. Thank you, Dr. Bhanu Pillai. So I'm just sharing my screen just for a second. So can you see the screen, sir?
Yes.
Yes. Okay, fine. So greetings from Institute of Liver and Biliary Sciences to everyone who has joined this meeting from India as well as abroad. So the topic which I have been given today is atypical presentations of viral hepatitis. Now, hepatitis A, as we all know, is a hepatotropic virus of Picorna viridae family and has 6 genotypes. The genotype 3 is important and relevant to us because it is the commonest genotype in India and neighboring countries. Now, for those of us living in the northern parts of India, hepatitis A is the single most common cause of pediatric liver disease in India, in this part of the world. It is the commonest cause of acute hepatitis, accounting for 70 to 80% of the cases, commonest cause of pediatric acute liver failure, and commonest acute insult resulting in pediatric ACLF. Now, if we talk about the presentations of hepatitis A, we believe that 90% of the children who get infected with hepatitis A remain asymptomatic. That is, they do not develop jaundice. The rest become symptomatic with jaundice. However, the jaundice is usually self-limited and usually resolves in 8 to 12 weeks of time. Now, what is known is, if you get a HIV infection in your childhood, that is in the first 6 years of life, more than 70%, it's close to 80 to 90% will remain asymptomatic. However, as the age of acquiring the infection increases, the chance of the hepatitis A virus infection becoming symptomatic is much higher, and above 18 years of age, more than 70% of patients will become symptomatic. So, among those who become symptomatic with acute hepatitis, around 1% will progress to acute liver failure, less than 10% will develop some other extrahepatic complications, and most of them will have a spontaneous recovery. Along with that, around 10 to 30% will develop what is known as atypical manifestations of atypical presentation of hepatitis A that I'll be talking today. But before understanding what is atypical presentation, we need to understand what do I mean when I mean a typical presentation of hepatitis A. So this is a typical presentation of hepatitis A. A young child, 5 years, 10 years, 12 years old, comes to us with a prodrome. By prodrome, I mainly mean the child will have a constellation of symptoms just prior to the onset of jaundice. So here the symptoms are mainly anorexia. Other symptoms may or may not be there. Then there is a gradual onset jaundice and and spontaneous recovery in around 6 to 12 weeks of time. Now the bilirubin you can see is elevated. HT will go very high in thousands. INR will be normal. IgM, HAV, that is how we diagnose acute hepatitis. So IgM, that is immunoglobulin M antibody, will be reactive, suggesting of acute infection. And if you do an ultrasound, it will show a hypoechoic liver, that is acute hepatitis, and acute acalculous cholecystitis, that is GB wall edema. Around a few of them, now this is a typical pattern, but a few of them will have a rapidly progressive course of jaundice, progressing to hepatic encephalopathy, and that is when we call them as acute liver failure. Now, as per data, less than 1% go into acute liver failure, but as per the data from the tertiary care centers or like data from our center, around 20% of us, the patients presenting to us with hepatitis A go into acute liver failure. Now, this is the typical timeline. IgM comes around.
Dr. Bikrant, your audio is not that clear.
Okay. Okay. Now, is it clear now?
Now it's better. Now it is better.
Yeah, I'll keep it closer to myself. So, so this is the typical timeline of hepatitis A. That is around 2 weeks, around 2 to 3 weeks of illness. We get IgM antibody positive, and it decreases by around 8 to 10 weeks and disappears by around 12 weeks. Then there is IgG antibody coming up, and this IgG antibody is protective against another infection of hepatitis A, and this antibody provides lifelong protection. Now, the virus in blood and virus in feces are present for only 4 to 6 weeks, and thereafter HAV RNA may be detected in blood or feces for as long as 3 to 6 months. So now, this is the typical manifestations: acute hepatitis and acute liver failure. So now, what are the various atypical manifestations of hepatitis A? Now, I have tried to classify the atypical manifestations in 2 parts: those which are liver related, and these are quite common, and those which are extrahepatic, which are not very common. So among the liver related complications, we have prolonged cholestasis, which is the commonest one. Around 15% of symptomatic acute hepatitis will develop this complication. Around 5% will develop relapsing hepatitis. Around 5 to 10% will develop ascites. And autoimmune hepatitis is a rare complication of hepatitis A infection. Among the extrahepatic manifestations, hemolytic anemia, whether related to G6PD or related to immune-mediated hemolysis, is common. Then there are acute pancreatitis, autoimmune thrombocytopenia, HLH, serositis, pleuritis, and pericarditis. So what you can see is the most of the atypical manifestations of viral hepatitis are due to the immune reaction to the virus and not due to the virus per se. Now let's see the epidemiology of these atypical manifestations. So these are the studies in pediatrics which describe the atypical presentations of viral hepatitis. As you can see, the first study from ILBS and the second study from SGPGI both came in 2019 and describe large cohorts of hepatitis A, close to 200 to 400 patients. And it is a consistent finding that around 30 to 40% will have some form of atypical manifestations. Maximum, they will have prolonged cholestasis, that is in 15%, relapsing hepatitis in close to 5%. And another important part is intravascular hemolysis. So whenever you are seeing a drop in hemoglobin, you have to suspect intravascular hemolysis, which could be due to virus or due to G6PD deficiency and the drugs that are being given to the patient at that time point. So this is a data which we published in 2019, where we show that out of 431 cases of acute hepatitis, 92 were acute liver failure, 13 were ACLF, and 326 were acute hepatitis. And as you can see on the left-hand side of the screen, 134 children had some or other form of atypical presentations like prolonged cholestasis, relapsing hepatitis, hemolysis, secondary HLH. You can see 9 patients developing secondary HLH out of 400 odd patients, AKI, and acute pancreatitis in 3. Similarly, the SGPGI data also shows the same pattern of extrahepatic manifestations. But what is important to note that symptoms like atypical presentations like prolonged cholestasis are more common in older children. Like you can see in children more than 10 years, prolonged cholestasis was more common. In contrast, ascites is more common in younger children. We'll come to the reasons when we take them one by one. So the most common atypical presentation is hepatitis A with prolonged cholestasis, which we have seen can be present in 10 to 15% of symptomatic patients. Now, why is there cholestasis in hepatitis A? Hepatitis A usually causes necrosis in the hepatocyte, so it should not cause cholestasis. But the virus is excreted through the biliary transporters at the canalicular membrane, and it has been shown in animal studies that hepatitis A virus causes down-regulation of biliary transporters at the canalicular membrane. Now, this down-regulation can be the effect of virus itself, or it could be the effect of the inflammatory mediators released in response to this virus. Now, why some patients develop cholestasis and others do not? Now, this could be mostly due to the host factors. We all know transporters. Nowadays, everyone is talking about progressive familial intrahepatic cholestasis. And we know that there are multiple defects in this bile transporters at the canalicular membrane. So it has been recently shown that some single nucleotide polymorphism in ABCB11, that is bile salt exporter pump, or in ABCB4, that is a multi-drug resistance protein which transports phospholipids, in the host can lead to these kinds of symptoms. Apart from it, is it related to the immune status of the host or nutritional status of the host? Is quite likely, because the patients with cholestasis are those who fail to clear their virus from the circulation quickly. So possibly the patients with a lower immune system, immunosuppressed system, or those with malnutrition may take longer time to clear the virus, resulting in virus causing direct downregulation of biliary transporters. Whether it is related to viral factors looks unlikely, because we recently evaluated the patients with cholestasis-like presentations and patients with acute liver failure-like presentation, and we found that the genotype was exactly the same. So what is the definition? The definition says jaundice should be there for more than 12 weeks to call it prolonged, and with pruritus to suggest that there is cholestasis, and jaundice should be more than 10. However, these definitions can vary from in various literature. So when to suspect? If you are seeing a deep jaundice and followed by pruritus, then you have to suspect, in an older child especially, then you have to suspect that it is cholestatic form of viral hepatitis. Now, the jaundice duration can go for as long as 4 to 5 months or 6 months, and jaundice to pruritus duration is usually varying between 2 weeks to 4 weeks. But the key is recognizing cholestasis, that is jaundice and pruritus. Duration may not be the key, because you don't want to wait for 12 weeks for the child to fulfill the definition for you to take action. We want to take action as soon as possible. And I believe that patients who develop cholestasis are actually the patients who are going to have a prolonged course. So earlier you intervene, the better it is going to be. The shorter it is going to be the course of illness in the patient, and hence the school absenteeism and all can be reduced if we diagnose it early. So that's why I think the duration is not important. So you just need to recognize clinical cholestasis in form of pruritus and deep jaundice, and you have to reassure the patient. Usually we found that the patients who develop cholestasis usually do not develop acute liver failure. So these are two different spectrums of of viral hepatitis A. So this is a typical case that we got recently, a 15-year-old child who started with anorexia, then developed jaundice, As the jaundice was not decreasing by 1.5 months, they went to some quacks and took some alternative medicine. But the jaundice continued to increase, and 1.5 months after the onset of jaundice, the patient developed severe pruritus, which was disturbing the sleep, and the patient had multiple abrasions and even some bleeding from some parts in the lower limb. Now, if you see the LFT, the bilirubin is quite high, unlike the typical presentation where the bilirubin was not very high. AST, ALT are not very high, they are in hundreds, unlike the typical presentation where it was in thousands. The serum creatinine is high, and the reason for that you can see is urine RM shows bile cast. So whenever the jaundice is high, whenever the bilirubin is high, the bilirubin forms cast in the glomerulus, and these bile casts can cause bile cast nephropathy leading to AKI. So this was the presentation. Anorexia, which was persisting, was possibly due to the restricted diet that the parents were giving. They were giving him only boiled food. So any child who is being given boiled food would not have a taste for it, and that was possibly the reason why the child continued to have anorexia 2 months in the course of illness. Otherwise, the prodromal symptoms should subside at the onset of the jaundice. Now, what treatment did we give? We gave UDCA 600 mg twice daily. Child's weight was close to 60 kg. His pruritus did not improve for 48 hours. So finally, on day 3, we added rifampicin at 600 mg and hydroxyzine at 25 mg at bedtime. We also added fat-soluble vitamin supplements because there was cholestasis. We allowed him all kinds of diet, and fluid intake was encouraged, oral fluid intake, because of presence of bile cast nephropathy and increased creatinine. We explained them about the possible need for plasmapheresis if the bilirubin goes further high, or for CRRT if the AKI worsens further. However, with the medical therapy, his jaundice started decreasing, and you can see by 10 days, the bilirubin had decreased from 45 to 31, AST, LT were almost same, creatinine had normalized, and pruritus had almost disappeared, following which the child was discharged from the hospital. So this is the usual course of acute viral hepatitis with cholestasis. The key to management here is parental as well as reassurance of the doctor who is referring the patient to you. Because still we see daily that the patients who are coming to us are on a very restricted diet. They are not given fats. They are not given turmeric. They are only given carbs, maybe sugarcane juice, maybe rice, curd. That is all that they are prescribed. And that causes severe malnutrition and prolonged course. So the parents as well as the referring doctor has to be reassured that this all will resolve. You have to allow a good diet, a balanced diet, no restrictions, no CAM, no alternative medicines. UDCA, rifampicin, I would like to mention that it is safe. You should not be afraid to use rifampicin, because in patients with Alagille syndrome and PFIC, it has been found to be extremely safe, even with very high bilirubin like 30, 40 mg per deciliter, or with high ALT. Now, we are using monotherapy of rifampicin, so we should not be scared about the hepatotoxicity, which is very infrequent with rifampicin alone. Now, I would suggest the audience to avoid cholestyramine because it causes a lot of malnutrition. It is a bile acid binding resin, so it will bind the fat soluble vitamins. It will prevent the absorption of fat soluble things, so it should be avoided. And steroids are being recommended mainly in the adult hepatology side, but in our experience, we have not felt the need for steroid in any patient, and everyone responds to UDCA plus minus rifampicin. Now, coming to the second most common, that is relapsing hepatitis. Now, relapsing hepatitis we call when there are 2 or more episodes of acute hepatitis with intervening periods of remission. Now, periods of remission will have remission of clinical symptoms and decreased liver enzymes. Now, this relapse, which is happening after a period of remission, will either be a clinical relapse in form of jaundice, a biochemical relapse, that is again a rise in AST/ALT, and ideally, as per definition, there has to be a virological relapse, that is HAV RNA should again become detectable in the serum or in the feces, but this is not practical. So we have to mainly diagnose this again clinically. The pathogenesis of relapsing hepatitis is there is the persistence of hepatitis A virus usually circulates in by forming an immune complex with IgA. So persistence of this HAV IgA immune complex in circulation, which can cause reinfection, is usually suggested as the cause of pathogenesis of this relapsing hepatitis, especially in patients with immunodeficiency. So this relapsing hepatitis was first described in patients with HIV. So when there is immunodeficiency, there is failure of clearance of HIV, and this relapse can occur in these patients. DD, a closed DD is a double infection with HAV and HEV. So both of these viruses come from a same site. They have fecal-oral contamination. So both of them can enter together. HAV has shorter incubation period. HEV, hepatitis E, has longer incubation period. So they can come as two distinct illness and look like relapsing hepatitis. Then there can be superimposed drug-induced liver injury, or the first part could be acute viral hepatitis, and the second jaundice could be autoimmune hepatitis triggered by the virus. So how is the diagnosis? Mainly clinical. Presence of IgM HAV does not help because as I showed in the first slide that IgM HAV can normally be present for prolonged periods like 8 weeks. So that doesn't help. And ideally, HAV RNA should be demonstrated in stool, but that may not be feasible. So it has, a clinical diagnosis should be made as far as possible. Treatment, the best part is the second jaundice is usually most likely going to be milder than the first episode. So this will not usually progress to acute liver failure. So just a symptomatic treatment, that is again uh, concentration on the nutrition of the child, UDCA, will help resolve this. And again, as far as possible, avoid steroids. If at all you have to use steroids, do a biopsy to document that there is some immune mediated damage ongoing. Without biopsy, it's a strict no. Now, the third most important part is HAV with intravascular hemolysis. So when do we suspect HAV with intravascular hemolysis? When there is drop in hemoglobin, when there is elevated unconjugated fraction, like 40 total bilirubin, 30-35 is indirect. So unconjugated fraction, and if there is cola colored urine. So then we suspect intravascular hemolysis. Now, intravascular hemolysis in HAV, as I already described, could be due to HAV induced immune hemolytic anemia. So that will be DCT, Coombs test positive and retic count high. And second, it could be due to G6PD deficiency, which is common in central parts of India, where the patient develops hepatitis A, then they get some drugs, and these drugs precipitate hemolysis. So both these things should be tested, and obviously you have to avoid, whenever there is hemolysis, consider that this could be an underlying G6PD and avoid the drugs which are not safe in G6PD, including injection vitamin K should be avoided if possible, although it is not proven to be really that harmful. Now, there should be increased fluid intake because when there is hemolysis, there can be AKI. And if there is ongoing hemolysis, severe hemolysis causing AKI, then you may need to do plasmapheresis to remove these hemolyzed products so that it does not cause renal injury. Now, coming to hepatitis A with ascites, it has been described in as high as 20% of patients with acute hepatitis, commonly in younger children, mainly described by the SGPGI group. And it was found more commonly in younger children who had malnutrition and low albumin. So obviously, low albumin, you have acute hepatitis. Acute hepatitis can cause acute portal hypertension, and there will be some ascites. Usually, it will not be mild. It will not be massive ascites. It will be mild ascites, and usually it will resolve spontaneously. But what is to be kept in mind is whenever you see ascites in a patient with acute hepatitis A, always palpate his liver, spleen, to see for underlying evidence of chronic liver disease. But because what you could be dealing with may be acute on chronic liver failure. That is, a child had CLD, was completely asymptomatic for the chronic liver disease. Now he has an acute viral hepatitis, which precipitates an acute on chronic liver failure. In absence of an underlying CLD, the management is conservative and diuretics are usually not required. If required, it is required for a short course only. Acute pancreatitis is more of a complication in adults, very rare in children. Diagnosis and management is as per the standard acute pancreatitis guidelines. Best thing is hepatitis A induced acute pancreatitis usually has excellent recovery and no recurrence. Autoimmune thrombocytopenia can be again due to immune-mediated damage secondary to HAV. But what you need to consider is differential diagnosis like drug-induced thrombocytopenia. It could be underlying CLD with splenomegaly causing thrombocytopenia. It could be other tropical infections like dengue, malaria, or it could be sepsis. Platelet transfusion are rarely required. And if you prove that it is autoimmune thrombocytopenia, then you may consider steroids, but again, rarely required in children. The last complications that I'd like to come to is HLH, hemophagocytic lymphohistiocytosis. Now, we had 9 patients out of 400 who developed this complication, which is actually quite rare. Now, when to suspect? Normally, hepatitis A fever occurs for first 2 to 3 days and fever goes away and the patient should only have jaundice. If there is persistent high-grade fever with splenomegaly, suspect HLH, especially if there's bicytopenia or pancytopenia. Then you need to do all the tests like ferritin, soluble CD25 and bone marrow, which will demonstrate more than 3% hemophagocytes. Again, good thing is HAV-induced HLH usually reverses with therapeutic plasmapheresis plus IVIG or steroids, and chemotherapy is rarely required, unlike other causes of HLH. HAV can also trigger autoimmune hepatitis, but it is again rare, and there are only case reports and case series. Diagnosis and treatment is as per standard guidelines, and it should be biopsy-based itself. So, general do's and don'ts for atypical presentation of hepatitis A. This is for the pediatricians. The current recommendation is no restriction in diet at all. The patient should be encouraged to take actually a high protein and actually slightly more than normal fat in the diet. No need of rest, no need of bland foods, no need of glucose water, sugarcane juice, carbohydrates. They should be specifically mentioned not to take any herbal medicines or medicine from unregistered practitioners. And the only treatment required is UDCA, multivitamins, and rifampicin if there is severe pruritus. And lastly, prevention, is better than cure. So hepatitis A vaccine would be the ideal goal, as you can see in the lowermost part, that we, with India is now going into the transition phase from an endemic pattern, from a high endemicity to intermediate endemicity. And so vaccination may help overcome this and to decrease the load of viral hepatitis. So to conclude, atypical presentations are quite common in hepatitis A infection. The good thing is most of them are self-limiting. Prolonged cholestasis, recurrent hepatitis, and intravascular hemolysis should be suspected, especially because if you diagnose them early, you will prevent the patient from going unnecessary diagnostic tests and unnecessary therapeutic modalities. And you can use, whenever dealing with ascites or thrombocytopenia, always rule out underlying CLD. And the management is usually very conservative management is works in almost everyone, almost in 100%. That is only UDC and multivitamin, nothing else apart from that, with good nutrition. Thank you.
Thank you very much, Dr. Vikrant, for that wonderful talk. And I think we can answer the questions to Vikrant right now. So in case if we get disconnected, so they can, the questions are there. So there are some questions from the IAP. One is, what is any role for steroids in relapsing hepatitis A?
So this part I have already covered in my talk, that there is no role of steroid in relapsing hepatitis A. Just treat it conservatively. If at all you are suspecting that it is autoimmune hepatitis, which is extremely rare. So consider that there is no role. If at all you have to do biopsy and all the workup of autoimmune hepatitis, we have hardly required to use steroids in any of these patients.
The second question you already answered with the part of the first question. What's the percentage of HEP patients getting autoimmune hepatitis? So I know it is very rare, but I don't know whether you have
0.5%, 1 in 200 maybe, or even less than that. I think it will be very less.
Yeah. And the third question was why the pruritus happens in hepatitis A.
So this I have explained, but I'll just tell once again if I was not clear, maybe or audio was not clear at that time. There are bile acid transporters at the hepatocyte level. So bile acids are made in the hepatocytes. They are synthesized in the hepatocytes, and then they are transported across the hepatocytes by certain transporters into the bile duct and then into the intestine. So the virus itself can block this. It can down-regulate these transporters. That it will decrease the number of active transporters at the canalicular membrane, hepatocyte membrane, and the immune activation that is there. The cytokines will also down-regulate this transporters at the canalicular membrane. So the bile acid which is present in the hepatocyte will not be transported properly into the bile ducts. So they will ultimately leak into the blood, and these bile acids are extremely pruritogenic. So if you do the bile acid level of these patients with cholestasis, you'll find it like normal is less than 10. You will find it will be like 130, 140, or maybe 50, 60, at least more than 50. That is what we find. Yeah. And then there may be some role of genetics, like some of the patient may actually have a polymorphism. Polymorphism means variations in the genetic makeup of these biliary transporters. So these are the common causes of cholestasis, and this is quite common. We see it day in and day out, this cholestasis in hepatitis A.
Actually, there was one more question. That's the last question. Is there any role for hepatitis A vaccine after recovery from hepatitis A infection?
So this again I have answered. I just reiterate again that once the hepatitis A infection occurs, IgM antibody forms, and then by around 5 to 6 weeks, IgG antibody forms, and this IgG antibody is protective against hepatitis A, and this IgG antibody persists throughout life. So once a hepatitis A infection happens, the child or the person is immunized. He gets immunized for life. So there is no role of vaccination if you have got a hepatitis A infection.
Thank you very much. And it has been a wonderful presentation, Dr. Vikrant. Thank you very much again.
Thank you.
May I invite Dr. Vipul Gautam. He is a consultant pediatric hepatologist at the Max Institute of Liver and Biliary Sciences. Dr. Vipul, he is going to talk about autoimmune hepatitis in children. Please, Dr. Vipul, please proceed.
Thank you. Thank you so much. So, I'm Dr. Vipul, and my topic of presentation today is autoimmune hepatitis. It's a last topic to cover, but I will try to rectify. I'll be covering this under following heads. First of all, the introduction of what autoimmune hepatitis actually is. Do we really need to discuss? What are the clinical features, spectrum of presentation, and the role of liver biopsy in various clinical scores that we often talking about autoimmune hepatitis, and what is the management, long-term monitoring of various immunosuppressants that we give. What is overlap syndrome? What is difficult to treat autoimmune hepatitis? The acute liver failure presentation, and always we face this dilemma of steroids versus liver transplant when a patient of autoimmune hepatitis present with liver failure. And post liver transplant, we talk about de novo autoimmune hepatitis and post LT recurrence. So I'll try to cover these things. If I miss something, pardon for that. So now I start. So what is autoimmune hepatitis? It is a progressive inflammatory disorder of unknown etiology. Although there is, it often said that there is some sort of infection or environmental toxin that leads to the exhalation of autoimmune cells like B cells and T cells against hepatocytes in a genetically predisposed individual, especially the HLA locus is involved, characterized by histologically by interface hepatitis and so many others, which I'm going to explain in upcoming slides. Serologically, there are so many autoantibodies that we can talk about. Biochemically, there is deranged LFT with elevated serum IgG, and clinically, it is characterized by the response to immunosuppressants. And first, we have to ensure that we rule out other causes of liver disease, especially the viral illness, Wilson, and even NAFLD nowadays, which is on rise. Yes, autoimmune hepatitis is common. From the Canadian cohort, we can say like 0.2 to 0.4 per 1 lakh. Although it looks rare, but in a setting of liver and biliary sciences where we do the practice, we often get these patients. And obviously, they are more common in females. And overall prevalence is rising, maybe because of rise in awareness and actual increase in prevalence leading to this various virus infections and so many lifestyle factors. Coming to the Indian scenario from ILBS, the experience is out of 500 chronic liver disease patients that we encountered, almost 56 were autoimmune hepatitis, that is almost 10%. And SLA presentation is not uncommon. There are two types of autoimmune hepatitis based on the antibodies that we talk about, like ANA and asthma positivity is seen in type 1, and LKM or LC1 is seen in type 2. In type 1 is obviously common than type 2, as we know, and however, the age of presentation is different, which I will discuss in the clinical slide. So pathogenesis, as I discussed, there is uncontrolled cellular response, also humoral, against the hepatocytes. The trigger is also not known, but it is said that there is some sort of infection or environmental toxin in a genetically predisposed individual that leads to this abnormal autoimmune response against the hepatocytes. So this is very important slide. Autoimmune hepatitis can present just with asymptomatic rise in transaminases to fulminant hepatic failure. It can range from just like any other acute viral hepatitis to cirrhosis to decompensation to end-stage liver disease to just portal hypertension to acute and chronic liver failure or ALF. Almost 60 to 80% of the patients who first time present to us are already cirrhotic on presentation, as we can see in this study from ILBS, where almost 80% of the patients were already cirrhotic at the time of presentation, and only 15% presented like acute hepatitis, 7% were ALF, and 13% were acute and chronic liver failure. Clinically, when we talk about autoimmune hepatitis, this disease is characterized by relapses in platelets and there is spontaneous remission. So we often get the history of coming and going jaundice, and this often leads to the delayed and misdiagnosis. And when the patients come to us, they are already cirrhotic. So often we miss these cases. And this is again the same thing. The type 1 and type 2 autoimmune hepatitis, we should know the difference. The type 1 is has a bimodal presentation in children and in early adolescent pre-pubertal age. We often see these patients with cirrhosis. And type 2 is often seen in infantile period. Sometimes they present with infantile liver failure, and in early childhood they often present with the liver failure. So obviously type 2 is worse than type 1, and clinically we can differentiate by the age of presentation and the way they are behaving. And by autoantibodies wise, ANA and asthma are positive in type 1 and LKM, LC1 are positive in type 2. Disease severity is very severe in type 2 as compared to type 1. Both of them respond to standard immunosuppression. However, type 2 often require liver transplant in view of liver failure at presentation. Apart from this jaundice, they also have, just like any other autoimmune disorder, other extrahepatic autoimmune involvement, like autoimmune hemolytic anemia, celiac disease, vitiligo, and inflammatory bowel disease. There are so many. Almost 20 to 40% patients do have some sort of autoimmune disease apart from liver disease. And up to 40% patients can have family history. Depending on the series, some say 10%, some say 40%. But we should always take the history of family and extrahepatic involvement. So before proceeding further, I want to clarify one terminology that we often encounter, overlap syndrome or autoimmune sclerosing cholangitis. And now this terminology was explained by International Autoimmune Hepatitis Group, where they found concluded that the autoimmune sclerosing cholangitis or overlap syndrome is the word that is used for those patients who have clinical features of autoimmune hepatitis and PSC, where there is overlap. Histological features of autoimmune hepatitis, raised IgG, autoimmune antibodies are positive, and at the same individual, they also have cholangiographic findings of sclerosing cholangitis. There are strictures, bleeding, and tree-like patterns. So those patients who have both of these are the actual overlap syndrome. And we need to discuss this because they often are not that responsive to management, often require interventions for strictures, and often lead to transplant. And even after transplant, they do have complications. And these are the individuals who are prone to have inflammatory bowel disease. If autoimmune hepatitis say has 20%, then they do have like 40%. So diagnosis is a very challenging in autoimmune hepatitis because there is no single test that can conclude that the patient is autoimmune or not. There is the background of deranged LFT where we have high bilirubin or high transaminases. There is elevated serum IgG, positive autoantibodies, liver histology, which I'm going to discuss, and there is response to immunosuppressive treatment. As I said, we have to rule out other causes of liver disease before diagnosing as autoimmune. This is the simplified score proposed by International Autoimmune Hepatitis Group. Initially, it was proposed in 1993, but various modifications happened, and this is what we follow from 2008. And in this, we can see that first point is autoantibody. If ANA or asthma are positive, with a titer of more than 1:40, we give 1. If it is more than 180, we give 2, because more the titers, more specific it becomes. And LKM, it gives 2. SL is another autoantibody that is like specific, but also predict poor outcome. Other thing is IgG. We have to see what IgG is. If it is more than upper limit of normal, then we give 1. If it's more than 1.1, we give 2. And liver histology has to be seen. I'm coming on that also. And we have to rule out other causes of hepatitis like viral and all other. If the score is more than 7, we could diagnose them autoimmune and we start the treatment. However, this score has some like limitations. This score does not discriminate between autoimmune hepatitis and overlap. So if we just go by this score, then we often miss like PSC and sclerosing cholangitis part, because there is no cholangiogram in this score. So in 2017, this European Society came up with this scoring system, in which they included cholangiography and also extrahepatic autoimmunity and family history. And if there is cholangiographic findings, then they give negative points to autoimmune and positive point to ASC. So with this score, we can actually rule out the presence or absence of sclerosing cholangitis, and this is the better as compared to simplified score. And this society proposed MRCP in all the cases of autoimmune hepatitis, because what they say in many of the patients at presentation, if there is no cholestasis, maybe later on they will develop, and better to rule out at the beginning only, because they often have this no response to treatment. This is a study from ILBS where they compared all the scores and they found no difference in the predictive value. These are the this is a slide about autoantibodies. As we discussed, this ANA, asthma, predict autoimmune type 1, LKM, LC1, that is liver kidney macrosomal 1, and the liver cytosol 1 type 2. AMA is basically seen in adults, and it has negative points for autoimmune hepatitis. And this predicts primary biliary cirrhosis, ASLA is specific in worse outcome. That is soluble liver antigen. P-ANCA is often seen in sclerosing cholangitis. However, in autoimmune hepatitis also 20 to 45% can be positive. As compared to adults, even the low titer is significant in children. For example, in adults, normally dilution of 1:40 is considered to be significant. But in children, coming to AN and asthma, more than 1:20 is significant, and LKM even more than 1:10 is significant. And some centers use like more than 1:80 when they want to increase the specificity of these autoimmune markers. We often talk about seronegative autoimmune hepatitis, because many a times we are strongly suspecting autoimmune hepatitis, but we get all the autoimmune markers negative. And then what to do in such condition? Is it normal? Yes, there are so many studies on this seronegative autoimmune hepatitis. Up to 75% of the children who have autoimmune hepatitis do have negative autoantibodies. So we should not just rule out autoimmune hepatitis based on single testing of autoantibodies. Sometimes they are like negative and once, and on follow-up they become positive, especially in case of fulminant liver failure. In our experience, whatever patients we see as a ALF or ACLF, they do have negative autoantibodies, and on follow-up they develop positive antibodies. So they should be put on follow-up, and they should be closely observed. And apart from this diagnosis dilemma, they behave exactly like any other typical autoimmune hepatitis. They show good response to immunosuppression, and everything is like any other case of autoimmune hepatitis. So coming on histology, histology is very important when we diagnose autoimmune, because so many times, for example, seronegative autoimmune hepatitis, we do not have any autoimmune markers. We do not have any feature suggesting of autoimmune hepatitis, then especially in the fulminant cases. So in such condition, histology is the only thing which gives a clue, and we can save these children using immunosuppressants. The most sensitive is interface hepatitis, that is a spillover of plasma cell lymphocytes beyond limiting plate into the lobules. There are so many plasma cell infiltration in the portal tract. There is zone 3 inflammation and necrosis. There are rosette formation, and the most specific is emperipolysis, which is one cell engulfs another. In this case, hepatocytes engulf lymphocyte. When it is seen, it is like specific for autoimmune hepatitis. And nowadays, some studies are going on Highline, Broca's, and Kupffer cells, which represent IgG in the cells. But so many times we have these patients of acute liver failure, acute and chronic liver failure, where we do not get these typical histological findings. We often, so what are the pointers in such cases? There are type 4 or 5 massive hepatic necrosis. There are lymphoid aggregates. There is zone 3 involvement, central perivenulitis, and plasma cell enrichment. These things lead to the diagnosis of autoimmune hepatitis when nothing is coming out to be positive. And this is just a paper from ILBS where they have said that ductular proliferation, ductular bile plugs, eosinophilic degeneration, and confluent necrosis predict poor outcome. So now we know how to diagnose and what are the antibodies histology used, so how to manage. The management of autoimmune hepatitis is quite tricky. First of all, we need to induce remission. Then we maintain the patient in remission. That is the main thing. Biochemical remission, that is the normalization of IgG after starting treatment. Negative autoantibodies or even low titers are important, and histological remission often follows biochemical. So how do we proceed? First of all, we on the diagnosis of autoimmune hepatitis, we start steroids at the dose of like 2 mg per kg per day with a maximum of 40. And depending on the centers, azathioprine is also started at the beginning, and some centers start after 2 weeks, or some start after the maintenance, after the remission is achieved. In such conditions, if the bilirubin is like high, more than 5, INR is like more than 1.5, patients are advanced to cirrhotics, and there is fulminant presentation, azathioprine is usually not started because azathioprine itself is hepatotoxic. So only in those conditions who is there is no decompensation and liver functions are not that bad, in such condition, azathioprine can be started. So with the help of this azathioprine and prednisolone, we induce remission. Gradually we taper down steroids. We come to minimal dose of like 0.1 to 0.2 mg per kg per day. Some go for like alternate day regime, and some even go for monotherapy azathioprine. We often go for monotherapy azathioprine because these patients usually present in prepubertal age, and in this age group, giving steroids is sometimes tricky. There are so many centers that talk about TPMT level, that is thiopurine methyltransferase. It is actually the enzyme which is involved in the metabolism of azathioprine. So if the level, like in 2% homozygous patients, the level of TPMT is very low. In such condition, there is high chance of developing bone marrow suppression on starting azathioprine. So they often need to reduce the dose of azathioprine or even avoid it. However, the routine screening is not recommended. Even only if the patient is having severe side effects of azathioprine, TPMT level can be considered. This is the regime. Initially, prednisolone azathioprine can be used for induction of remission, and the maintenance can be done with prednisolone plus azathioprine or azathioprine alone. And in overlap, UDCA is added along with the same regime we follow. And how do we define remission? There are 3 types of remission that we talk about when we're talking about autoimmune hepatitis. First is clinical remission, where child becomes clinically asymptomatic. Second is biochemical remission, where liver function tests are getting normalized. It can take up to 6 months for the LFT to normalize after starting immunosuppression. And IgG becomes normal as compared to the reference range, that should come down. And autoantibodies often become negative, and if not negative, at least titer should go down. So if a patient is in remission, then we maintain the same therapeutic and we continue whatever is going on. And if everything is going fine, and for the last 2 to 3 years, patient is absolutely fine and in remission, we can try for treatment withdrawal as well, which I'm coming in the upcoming slides. So what is the why did we study this overlap management? Overlap management is just like autoimmune, but it is often difficult to treat. Despite adequate immunosuppression, 50% have progressive biliary disease. They keep on having biliary disease and still liver disease, and there is higher relapse even on treatment. And if you go for transplant, there is higher post LT recurrence. And UDCA can be tried, although it is debatable. As we talk about the azathioprine metabolites, when a patient is on maintenance therapy, sometimes during maintenance, liver functions get deranged. Then we need to assess these azathioprine metabolites. Like, what is the role of TPMT? TPMT is the enzyme that that degrades this 6-mercaptopurine to 6-methyl-mercaptopurine, which is an active metabolite. And if the TPMT level is low, in West, like 2% are homozygous and 11% are heterozygous. In such conditions, azathioprine conversion to 6-thioguanine, which is the active metabolite, is high. in such condition, along with clinical efficacy, that is immunosuppression, there is also bone marrow suppression. So these patients who are TPMT deficient often have bone marrow suppression, and in such condition, we need to reduce the dose. But it is not recommended to test it before starting the therapy. And just I can skip this. So recommendation wise, there is no association between thioguanine, methyl mercaptopurine, and TPMT activity and the development of leukopenia. During maintaining the remission, as we know, this 6-thioguanine is the active metabolite that is responsible for the immunosuppression. It actually halts the purine synthesis pathway and leads to the apoptosis of lymphocytes also. So Tgen concentration of more than 220 is usually maintained. If a patient is not having controlled disease, we just test this Tg, and if it is low, we can increase the dose. And if it is high, we need to change the immunosuppression also. I discussed this. So if a patient is like difficult to treat and not getting response even after starting immunosuppression, what should we think about? First of all, we have to see the non-compliance, because these patients are often in the adolescents and they have behavioral issues, so they often miss the drugs. So first of all, we have to check the compliance. Sometimes they are hypermetabolizer, like they metabolize the drug too fast, and sometimes there is toxicity of byproducts like 6-MMP. These things can cause hepatotoxic. There can be overlap conditions like NASH or PSC. There can be drug-induced liver injury. Sometimes the patient is taking some drug apart from the immunosuppression that can lead to drug-induced liver injury, and sometimes there can be concomitant virus infection or non-hepatotropic or hepatotropic. These are the second-line drugs when our standard management of prednisolone and azathioprine fail. We can use as a second-line drug. We can use MMF, and if even MMF fails, then we can use cyclosporine or tacrolimus. So we're talking about treatment withdrawal. Not all the patients, but up to 20 to 40% of the patients who are in remission can be tried for treatment withdrawal. And rest of the patients often develop relapse after discontinuing the treatment. Most of the patients who we withdraw the drugs, relapse occurs within first 12 months. So we have to monitor like LFT every 3 monthly after stopping the drug, and even 2 weekly if required. So it is difficult, and especially in those patients who are like cirrhotic, who are already developing a flare during the treatment, and in prepubertal age, we should not discontinue, because if we discontinue in a prepubertal age, then relapse will happen, and in case of relapse, we need to give steroids, and giving high dose steroids in a puberty is not a good idea. And we're talking about this autoimmune hepatitis related liver failure. In ICU settings and in so many settings, we often get this liver failure related to autoimmune hepatitis. As we discussing, up to 7% can have ALF. So the question arises, what is the management of this liver failure? Should we go for upfront liver transplant, or we can give a trial of steroids? There are so many studies. In adults, we often say there is the risk of infections and delay the listing of LT and so many things. So they directly go for liver transplant. Unlike adults, in children, up to 50% patients do have a good prognosis after starting steroids. There are so many papers that show even in a follow-up period of 2.5 years, patients do well when they presented with liver failure, and they recovered with steroids alone. So in talking about children, if a child presents to us with liver failure, if it is not advanced hepatic encephalopathy, and if there is scope, then we should definitely try steroids before proceeding for liver transplant. In this study, it has shown that up to 50-90% of patients showed good response after starting steroids, and they did not require liver transplant. However, one thing to be noted is these patients all were not in HE, or just grade 1 to HE. So using steroids was justified. And those patients who expired on steroids had infection. So infection monitoring is very important if we start steroids in a liver failure patient. This is again the same paper. This is the ASLD guidelines on how to define acute severe autoimmune hepatitis and acute severe autoimmune hepatitis with ALF. So if a patient comes to us with acute severe autoimmune hepatitis where INR is more than 1.5, but there is no hepatic encephalopathy, should we go for transplant or steroids? If there is no HE, then we can try steroids, and we have to assess biochemically like 3 days or 7 days with INR, platelets, and bilirubin. If it is going down, there is improvement, and there is no worsening of HE, there is no infectious episode, we can go ahead with the steroids and we can continue, and later on we can also add azathioprine. However, if the patient develops some sort of infection, if there is worsening of HE, if there is no biochemical involvement, then we should list the child for LT. And since we are working in a living donor transplant setting, so we can start donor evaluation. However, if a patient presents to us with autoimmune hepatitis and acute liver failure, that is INR is more than 1.5, and there is already onset of hepatic encephalopathy there. In such patients, they should be directly listed for liver transplant. However, since we are in a living transplant or living donor setting, so we can time the LT. And in the meantime, if the hepatic encephalopathy is not advanced, with a mutual consent and mutual discussion with the family, in few patients we can start steroids, take a trial. If HE worsens, then we have to straight away go for transplant, and we can take a trial if HE becomes okay. If there is improvement, we can avoid transplant. However, this category is little risky, so this needs proper discussion with the family. So in children, there is definitely proven role of steroids. Up to 50 to 90% respond, may be related to different biology and reversible nature and better regenerating capacity of pediatric liver. However, we should avoid steroids in advanced HE. When there is HE, we should never delay listing, because sometimes if the patient suddenly goes into HE, we don't have enough time to evaluate for donor, and we lose the child. And we have to be very careful for septic complications. We had some, I think I'm running out of time, so I'm skipping the slide. So the post-LT recurrence, many a times when a patient of autoimmune hepatitis goes for transplant, after the transplant, they develop the same disease again, that is post-LT recurrence. The diagnostic criteria remains just like any other regular case of autoimmune hepatitis. There is elevated transaminases, there is hypergammaglobulinemia, positive autoantibodies, histopathology is typical, and they often respond to increasing the dose of steroids. And we have to exclude other differentials when we are dealing with the graft dysfunction, like there can be any acute rejection, there can be viral infection, there can be vascular findings, there can be structural, so many things. So first we exclude everything, then we evaluate for post-LT recurrence. And up to 40% of the patients do have recurrence. Most commonly it is seen in autoimmune hepatitis type 2. As we see in this paper, out of 5, 4 patients had recurrence. And autoimmune hepatitis type 1, out of 8, only 1 had recurrence. So autoimmune hepatitis, just as I said earlier, is always a notorious thing, and it behaves in a very, very bad manner. The one thing to note in this paper is 75% of these patients who developed recurrence were not on steroids. Normally, various centers in transplant setting taper down steroids and stop it, like after 3 to 6 months. And these are the patients, especially in the autoimmune hepatitis, who develop recurrence. So one lesson we learn here is that in patients of autoimmune hepatitis, we should not stop steroids. Maybe we can give a low dose, but it should be continued. And medium interval for recurrence is like 33 months. So again, the same thing, long-term steroids reduce recurrence of AIS significantly. However, we have to keep a check on sepsis and osteoporosis. And if we are regularly using steroids, then endocrinology opinion is required. So caution is required when we are giving steroids or not. If a patient is a low risk of AIS recurrence, like pre-LT activity was normal and there was acute severe presentation, these are the patients who do not develop autoimmune recurrence. So if a patient falls in this category, if there is high risk of osteoporosis, then steroid withdrawal can be tried. And if a patient had severe disease, activity in explant, high IgG, that is the disease was not controlled before going for liver transplant, and there is risk of rejection, in such patients, steroid should not be discontinued. So proposed management is just like any other autoimmune, and also taking consideration of post-LT. We give triple immunosuppression, that is tacrolimus plus azathio or MMF plus steroids. So we have to escalate steroids for some time to induce remission. We continue or add azathioprine, and if intolerant, then mycophenolate mofetil. And tacrolimus is the must for any post-liver transplant patient, so it has to be continued. Apart from post-LT recurrence, there is a terminology that is known as de novo autoimmune hepatitis. That is, this is occurrence of autoimmune hepatitis in a post-liver transplant patient who was diagnosed to have some disease which was not autoimmune hepatitis. That is, there was something else for which he was transplanted, and now, unfortunately, the graft liver is developing autoimmune hepatitis. That is what de novo autoimmune hepatitis actually is. And again, the diagnosis is just like any other autoimmune hepatitis, and treatment is just like as I mentioned earlier. So summarizing, autoimmune liver disease has a varied spectrum of presentation from acute to chronic, from just transaminases to permanent hepatic failure. Liver biopsy plays a crucial role. When everything else is coming negative, liver biopsy helps us. Cholestatic variants and overlap syndrome should always be looked for because they affect prognosis, management, and counseling of families definitely rely on this thing. Treatment withdrawal can be tried with only 20 to 40% of success. However, in those patients who are like cirrhotic, prepubertal age, who have lapses during treatment, and especially autoimmune hepatitis type 2 overlap, these patients are the one who in which we can avoid treatment withdrawal. Steroids role is well proven in age-related liver failure, provided there is no advanced HE and the patient is not septic. The role is debatable in adults but beneficial in children. And as I explained, post-LT recurrence is not uncommon, and steroids are protective. Long-term steroids can be given. And thank you, everyone. I take this opportunity to invite you all for the 6th International Congress of International Living Donor Liver Transplant Group. The theme is Liver Transplant Beyond Borders. It is being held in Hotel Hyatt, Jaipur, from 17th to 19th of November this year. You all are welcome here, and thank you.
Thank you very much, Dr. Whipple, for that wonderful and exhaustive talk. And
Thank you, sir.
there were some questions in the chat box. One of them was, when will you consider decreasing the dose of the immune suppression? Is it after 2 years of being normal AST/ALT, or will you wait for the IgG to be normal also before we start, considering stopping the immune suppression?
So when we start standard immunosuppression after diagnosing autoimmune hepatitis, we start with like 2 mg per kg of prednisolone, and simultaneously you can start azathioprine also. And as the AST/ALT and liver function tests are getting normalized, clinically child is getting better. Parallel to that, we keep on decreasing prednisolone dose, and by like 6 to 8 weeks, we come to a minimal dose of 0.1 to 0.2 kg, provided LFT is getting better. And in the meantime, azathioprine takes over, and we can continue azathioprine plus steroids for some time, and then if patient is allowing us, if IgG is getting normalized, if everything is getting better, then we continue with azathioprine. But if there are lapses, then we have to continue low dose steroid for a long time.
There were some questions from IAP, and which I think you already dealt with. That one was how long the treatment of autoimmune hepatitis. Another one was what's the percentage of association with the celiac, diabetes mellitus, IBD, etc. in autoimmune hepatitis. I think you already covered those things in your talk, I think, but maybe you are talking a little too fast for them to get it. That may be what happened, I think.
I took up my notes.
You may want to just reiterate those two answers for them to be clear, so that everybody have that clear idea when they go.
Almost 20 to 40% patients do have extrahepatic autoimmune disease. Like most commonly is like vitiligo, autoimmune hemolytic anemia, celiac disease, and inflammatory bowel disease, diabetes mellitus type 1, thyroiditis. So these things are seen in like 20 to 40%. I'm coming on that. This is the Indian paper from ILBS.
Yeah. There is one more question. One more question was, what is the dilution titers? Is it different in pediatrics versus adult?
Yes, sir. The dilution titer is different. In adults, we use like 1:40. If the titer is like more than 1:40, we often consider them positive. In pediatric, the cutoff is little low. For like in asthma and ANA, the cutoff of 1:20 is considered significant. However, if it is more than 1:80, that's more specific. But more than 1:20 is also significant. And LKM is, even if it is positive, it is significant.
Thank you very much, Dr. Whipple. Let me hand over the podium to Dr. Ramya.
Thank you, all of you. I think it was a very interesting session, and I think we have covered everything in our agenda. Let me first take this opportunity to thank both our speakers, Dr. Vikrant and Dr. Vipul. Presentations, I think they were very educative and very useful to all our fellow pediatricians and pediatric gastroenterologists who were listening throughout all over from everywhere. Thank you, both of you. They were fantastic presentations. I'm also indebted to Dr. Bhanu Vikraman Pillai, sir, who have chaired the session today. Thank you so much, sir. It was very nice hearing from you. And I think the audience were very interactive today. We had a lot of questions from them. It was a very interactive crowd. I think we should thank the audience as well for being very nice. I think a special mention to all the organizers. I know it was not an easy task to bring everybody together. They've done a wonderful job. Congratulations and thank you each and everyone from all the organizing team. Thank you very much. And I think the IT team has been splendid. We didn't have any hiccups and the IT team has done fantastically well. So congratulations and thank you to the IT team. I hope I have not forgotten anybody. So thank you everybody and hope you all have a good night or a good day. Thank you very much.
Thank you.
Thank you. Thank
Thank
you.
Thank you.
Thank
Bye,
you.
everyone. Bye.
Bye, sir.
Bye, sir.
Hello, bye, Ashay.
Bye, sir.
See you.
Ashay, क्या sir?